Okay, imagine this. Picture a big medical center, right? In one office, the COO is tearing their hair out because, well, staffing is a mess again. They just can't seem to predict how many patients are coming in next month. Chaos.
Yeah, that sounds stressful.
Then, down in the records department, they get this really urgent request. An older patient needs their entire 40-year medical history sent securely overseas for specialized care. It's got to be perfect and safe.
High stakes there too. Accuracy and security are paramount.
And then the very next morning, legal gets a call. A federal agency is investigating because apparently some former employee, maybe disgruntled, leaked hundreds of patient financial records onto the dark web.
Wow. Okay, 3 totally different nightmare scenarios.
Exactly. But here's the thing. The prediction problem, the secure transfer, the massive data breach, they all connect back to one single, really essential field.
And that field is health information management, HIM.
Right. HIM. It's kind of the invisible plumbing of healthcare. It manages all the data, the security, the legal stuff that makes patient care possible and safe.
So today, we're doing a deep dive into HIM. We've got your sources here, and our mission really is to get under the hood. We want to understand the legal rules, the tech, the ethics, all the standards that turn raw patient info that's primary data into usable knowledge, secondary data without compromising privacy or safety.
We're going to kick things off with the core idea of security, this CIA triad. Then we'll dig into the biggest threat. Spoiler, it's often us humans touch on things like whistleblower laws, and wrap up by looking at a surprisingly specific calculation hospitals use to figure out if a patient's death might have been, well, preventable and maybe their fault.
It's all about how managing data is managing patients, really. Let's jump in.
Okay, so when we talk health data, obviously protection is front and center. People often throw around security and privacy like they're the same thing, but they're not, are they? What's the key difference?
That's a really crucial distinction to make right at the start. So privacy, that's the patient's right. It's about controlling your own information, keeping it protected from, unwanted eyes.
It's the individual's control?
Exactly. Security, on the other hand, is the how. It's the actual measures, the tools, the policies, the procedures. Everything an organization puts in place to guard that data and the systems it sits on. Security is how you enforce privacy. Keep it safe from unauthorized access, use, changes, destruction. All those things NIST talks about.
Got it. So security is the operational part, the doing, and privacy is the right being protected. And the benchmark for good security is the CIA triad.
That's the one. Confidentiality, integrity, and availability.
Yeah.
CIA. And the key is you need all 3 all the time. If one pillar crumbles, the whole system is technically insecure.
Confidentiality feels pretty straightforward. Keeping secret, right? Protecting privacy.
It is. But I'd actually argue that integrity is maybe even more critical when it comes to patient safety. Integrity means the data has to be complete, accurate, consistent, and this is really important, up to date.
Why is that so critical?
Well, think about what happens if integrity fails. A lab result gets mixed up, a drug dosage is wrong, a vital sign is recorded incorrectly. Those aren't just data errors, they're potentially life-threatening mistakes. A confidentiality breach, hugely damaging, legally costly, yes. But an integrity failure, that could be lethal.
That really puts it in perspective. Okay, and the third leg is availability. This one feels like it gets overlooked sometimes. Data might be secure and accurate, but if the doctor can't get to it in an emergency,
then it's useless. Right. Availability means the system works when it's supposed to without glitches and delivers the info when and where it's needed. That's why robust backup plans and disaster recovery procedures are non-negotiable security elements. Think ransomware attack, natural disaster.
Yeah.
If the system goes down, availability fails. Care stops. The data might be safe somewhere, but if it's not available at the bedside, it's a massive security failure.
Okay, so we know what we need to protect the C, the I, and the A. But where do the attacks actually come from? The sources are really clear on this. The #1 threat category, more than any fancy hacking tool, is people.
Yeah.
Humans.
It's the constant vulnerability, isn't it? We talk about threats being internal, from inside the organization or external from the outside, but humans are the weak link in both cases, often. Your sources lay out 4 main types of human threats.
Yeah, walk us through those. They really cover the whole spectrum.
Okay, first up, insiders making unintentional mistakes. Just honest errors, clicking a bad link, forgetting to log out, maybe even misfiling something electronically. No bad intent, but still a risk.
Happens all the time, I bet.
Oh yeah. Second, Insiders who abuse their access. This is the classic snooping, looking up celebrity records or maybe checking on neighbors or family. It's usually not for profit, but it's a huge IPA violation, a major confidentiality breach.
Right. Driven by curiosity mostly.
Often. Third, insiders acting out of spite or for profit. This is more malicious. Stealing data to sell, maybe sabotaging systems on their way out after being fired.
Nasty stuff.
And finally, number 4, vengeful outsiders or organized attackers. These could be hackers, criminals, even nation-states sometimes, launching sophisticated attacks. But often, they still rely on tricking an insider, that human element again.
And that trickery often involves social engineering, right? Which sounds complex, but it's often surprisingly basic manipulation.
Absolutely. It's psychology, not usually complex coding. Social engineering is basically tricking people into giving up information or credentials they shouldn't. The attacker pretends to be someone trustworthy, maybe IT support, a vendor, even colleague, to get passwords, access codes, you name it.
And the classic example we all see is phishing. Those emails that look legit but have a malicious link.
That's the most common form, definitely. But it gets sneakier. You've got spear phishing, which is super targeted, maybe mentioning a project you're actually working on, making it seem much more credible.
Great.
Then there's baiting, leaving an infected USB drive labeled something tempting like Salary Info 2024 in the break room. Someone picks it up, plugs it in, bam.
Exploiting curiosity or greed.
Exactly. And don't forget the physical side, tailgating. Literally just following an authorized person through a locked door into a secure area. Low tech, but effective if people aren't vigilant.
So beyond the human tricks, there's the actual malicious software, the malware.
Right, the digital weapons. We know the usual suspects, computer viruses, worms. But one that's particularly dangerous for health info is the Trojan horse. Its whole job is often to sneakily copy sensitive files from secure locations to insecure ones on the network. A direct attack on confidentiality and integrity.
And then there's the one everyone's talking about lately, ransomware. That seems like a nightmare scenario for hospitals.
It is. Ransomware encrypts everything, locks you out of your own systems, your own data. Suddenly, that data is confidential, sure, but it's completely unavailable. Hospitals might have to revert to paper charts, cancel surgeries. It forces incredibly difficult decisions about paying huge ransoms just to get back online and care for patients. It hits availability hard.
Given this crazy landscape of threats, both human and digital, how does healthcare actually manage the risk? The sources point straight to the high-pay security rule. That's the main shield for electronic health information, or EPHI.
It's the bedrock, yes. The security rule mandates that every covered entity, hospitals, clinics, insurers, etc., must perform a thorough risk analysis. Figure out where their vulnerabilities are. What makes the rule work is its design. It's meant to be flexible. The specific measures can fit the organization's size and complexity.
So a small clinic doesn't need the same setup as a giant hospital system.
Exactly. It's also scalable for that reason. And importantly, it's technology neutral. IPay doesn't say you must use X firewall or Y encryption. Technology changes too fast. Instead, it mandates the outcome. The EPHI must be protected. How you achieve that outcome can evolve.
And we saw that failing to even do the risk analysis can be incredibly costly. That imaging company hit with a $3 million fine just for not doing one properly.
And that $3 million is often just the start. Think about the mandatory government oversight afterwards, the reputational hit, the sheer internal effort needed to fix everything. That often costs way more than the fine itself. It's a huge wake-up call.
So the security rule requires 3 main types of safeguards: administrative, physical, and technical. Let's start with administrative. These sound like the policies, the management side of things.
They are. These are the organizational rules of the road. You need a formal security management process. You absolutely have to designate a specific person, usually a chief security officer, CSO, who's responsible for security overall. You need clear workforce security policies, who gets access to what, background checks, termination procedures.
And training must be huge here.
Non-negotiable. Mandatory security awareness training for everyone, plus specific education for new hires. Everyone needs to understand their role in protecting data.
What about when something actually goes wrong, an incident happens?
There have to be documented security incident procedures. This is your playbook. It covers how to repair and report, fix the immediate problem, contain the breach, and then report it as required by law to HHS and potentially to affected patients and the media. And if it involves malicious action, deciding whether to pursue and prosecute.
And considering the availability risk we talked about, disaster planning?
Absolutely critical. The administrative safeguards mandate a contingency plan. This has several parts. A data backup plan. Where is data copied? How often is it tested? a disaster recovery plan, how to get systems back online after a fire, flood, cyber attack, and an emergency mode operation plan. That last one is key. How do you keep critical functions going when the main systems are down? Often means having procedures for reverting to paper charts or using specific downtime systems.
Okay, moving to the second category, physical safeguards. This sounds more tangible, locks on doors, that kind of thing.
Exactly. Protecting the actual hardware and environment. This includes facility access controls, locks, key cards, security guards, making sure only authorized people can get into areas where servers or terminals with EPHI are located. It also covers workstation use and security simple things, like requiring automatic screen locks after inactivity, positioning screens so passersby can't see patient info.
I saw the term ITAD in the sources, Information Technology Asset Disposition. That fits here, right?
Perfectly. That falls under device and media controls. ITAD is the formal process for getting rid of old computers, hard drives, backup tapes, either printers that might store data. You can't just toss them in the dumpster. They need to be securely wiped using specific software, degaussed using powerful magnets, or physically destroyed, shredded, basically to guarantee no patient data can ever be recovered. It prevents data breaches long after the equipment is gone. Also think about things like uninterruptible power supplies, UPS, to protect against power surges or outages.
Makes sense. Okay, finally, the technical safeguards. This is the technology itself, the controls built into the system.
Right. This is where the CIA triad gets enforced digitally. A huge piece is access control. Often this uses role-based access control, RBAC. The idea is simple. A nurse should only be able to access the information needed for nursing tasks. A billing clerk only needs access to billing-related info. You tailor access to the job role.
That directly supports that minimum necessary idea we'll talk about later.
Precisely. It limits exposure.
And how do you know if someone's trying to misuse their access or if something weird is happening?
That's where audit controls come in. These are essential. Audit controls basically log activity on the system. They create an audit trail that records who accessed what data, when they did it, what they did, view, edit, delete. These logs can be automatically monitored for suspicious activity like too many failed login attempts, someone trying to access VIP records, or accessing data that's totally unrelated to their job.
How detailed do those logs need to be, say, for legal purposes?
They need enough detail to ensure non-repudiation. That's a fancy term, meaning the user can't later deny they did something. So the audit log absolutely must capture 4 key things for every action: the date and time, the specific user ID, exactly what transaction occurred, for example, viewed patient X's lab results, and whether it succeeded or failed. That log becomes critical evidence.
And none of this works unless you know the person logging in is who they say they are. Authentication.
The foundation. Authentication verifies identity. It usually relies on one or more of 3 factors. Something you know, like a password or PIN. Something you have, like an ID badge, a smart card, or a security token generating a code. Or something you are. Biometrics, fingerprint, facial recognition, iris scan.
And combining factors is stronger.
Much stronger. Using any 2 of those factors together gives you two-factor authentication, 2FA, or multi-factor authentication. That makes it significantly harder for attackers, especially those using stolen passwords obtained through phishing or social engineering. It adds a crucial extra layer of security.
Okay, we've locked down the data, technically speaking. Now let's shift to the legal side. How is this data actually used and disclosed under the law? We need to start with where the laws even come from.
Sure. In the U.S., we're generally dealing with 3 main sources of law. First, you've got statutory law. These are the laws passed by Congress at the federal level or by state legislatures. Think HIP itself, that's a statute.
Okay, laws passed by lawmakers.
Second, there's regulatory law. Government agencies, like the Department of Health and Human Services, HHS, are tasked with implementing those statutes. They create specific rules and regulations to flesh out the details. The APOPA privacy rule and security rule are regulations created by HHS.
So the agencies add the operational details.
Right. And third, there's common law, also called case law. This is a law that develops over time through court decisions. Higher courts make rulings that set precedents, and lower courts have to follow those precedents in similar cases. Malpractice standards are often shaped by common law.
Speaking of malpractice, liability in healthcare often falls under civil law, specifically tort law. That deals with harm caused by wrongful acts.
Exactly. And when a patient sues a provider or hospital for medical malpractice, they're usually bringing a claim of negligence, which is a type of unintentional tort. To win that lawsuit, the patient, the plaintiff, has to prove 4 specific things.
4 elements, what are they?
First, duty. They have to show that the provider actually owed them a legal duty of care. Generally, once a provider-patient relationship is established, that duty exists.
Okay, step one, there was a responsibility.
Second, breach. The patient has to prove the provider violated that duty, that they failed to meet the accepted standard of care that a reasonably prudent provider would have offered under similar circumstances.
And the sources mention specific types of breaches like malfeasance and misfeasance?
Yes, those are important distinctions in how the duty was breached. Malfeasance is performing a completely wrongful or improper act, maybe even an illegal one, like performing surgery while intoxicated.
Clearly wrong.
Misfeasance, on the other hand, is performing a proper act, but doing it incorrectly or improperly. Maybe a surgeon performs the right procedure but does it negligently, causing injury. Or, in an HIM context, maybe a coder submits a claim, which is a proper act, but uses the wrong code deliberately to get higher payment. That improper execution is misfeasance related to billing.
Got it. So improper act versus proper act done improperly. If the patient proves a breach happened, what's next?
Third element, causation. This is critical. The patient must prove that the provider's breach directly caused the injury. There needs to be a clear link, often called proximate cause. If the breach didn't actually lead to the harm suffered, the claim fails, even if the provider was negligent.
The breach has to be the reason for the harm.
Right. And finally, fourth element, damages.
Hmm.
The patient has to demonstrate they suffered actual harm, which can be compensated financially. This could be medical bills, lost wages, pain and suffering, etc. If there's no actual harm, there are no damages to award. You need all four: duty, breach, causation, damages, or the negligence case falls apart.
Okay, that covers individual lawsuits. What about the government cracking down on fraud, especially against programs like Medicare or Medicaid? The False Claims Act, FCA, seems like a really big deal there.
Oh, it's huge.
Yeah.
The FCA is the government's main weapon against healthcare fraud, and it has this incredibly powerful feature, the quid tam provisions.
Quid tam, what does that mean?
It basically allows private citizens, who are called whistleblowers or relators in this context, to sue fraudsters on behalf of the government. If they have inside information about false claims being submitted, say for services never rendered, they can bring the lawsuit themselves.
Wow, so the government essentially deputizes citizens to fight fraud.
In a way, yes. And there's a strong incentive. If the lawsuit is successful, the whistleblower gets a percentage of the money recovered, which can be substantial. This turns employees, contractors, anyone with knowledge into potential fraud detectors. It puts tremendous pressure on organizations to maintain compliance internally.
And the penalties, if you're caught, they're not messing around, are they?
Not at all. They're designed to be crippling. Violators face treble damages. That's 3 times the amount the government was actually defrauded, plus hefty fines for each individual false claim submitted. If a hospital submitted thousands of false claims over years, the total penalty could easily reach hundreds of millions, even billions, potentially bankrupting the organization. It's a massive deterrent.
Okay, let's switch gears slightly to something HIM professionals deal with constantly. Requests for records. There's often confusion about a subpoena versus a court order. What's the hierarchy here?
This is fundamental. The key difference is who issued it. A subpoena, ducis decum, which just means a subpoena requiring documents, is issued by an attorney. Because it comes from a lawyer involved in a legal case, not a judge, it has less legal weight than a court order.
And crucially for healthcare.
Crucially, a subpoena alone is not considered a valid HIPAA authorization to release patient records.
So if an HIM department gets a subpoena from a lawyer asking for patient X's records, they can't just hand them over.
Absolutely not, unless it's accompanied by a specific authorization signed by the patient or meets other specific IPPay criteria, like assurance the patient was notified and didn't object. Generally, the custodian of the record receiving just a subpoena must first try to notify the patient, if allowed, and should definitely consult their legal counsel before releasing anything. Releasing records improperly based on just a subpoena is a HIPAA violation.
Okay, so subpoena attorney needs more validation. How does a court order differ?
A court order is issued directly by a judge presiding over a case. Because it comes from the court itself, it carries more legal weight. In fact, a court order can authorize the release of protected health information, PHI, without the patient's explicit authorization.
Why is that allowed under HIPAA?
Because disclosures required by a court order fall under a specific exception in the HIPAA privacy rule, often called the Judicial and Administrative Proceedings exception. When presented with a valid court order, the HIM department generally must comply and release the specified records. Refusing could lead to contempt of court charges.
Big difference then. Judge's order trumps the need for patient consent in that specific context.
Correct. But even when records are released, whether under court order or for routine things like billing or operations, another HIPAA principle applies, the minimum necessary standard.
Right. Tell us about that.
This is a core privacy protection. The minimum necessary rule requires that healthcare providers and other covered entities make reasonable efforts to limit the use or disclosure of PHI to, well, the minimum amount necessary to accomplish the intended purpose.
So don't share the whole chart if only the billing codes are needed.
Exactly. Why should the billing department see sensitive therapy notes if they just need diagnosis and procedure codes for the claim? It's about limiting unnecessary exposure of patient information, even for legitimate purposes. Reduce the risk by reducing the scope of access.
Makes sense. Are there times when minimum necessary doesn't apply? Situations where you can share more?
Yes, there are important exceptions. The minimum necessary standard does not apply to disclosures for treatment purposes. Clinicians treating the patient generally need access to the full record to provide safe and effective care.
Okay, treatment is wide open.
It also doesn't apply when the patient themselves requests access to their own records. They have a right to their full record. Or when disclosures are required by law, like reporting communicable diseases to public health authorities. And finally, if the patient has signed a specific, valid authorization form allowing a broader disclosure, that authorization overrides the minimum necessary default for that specific disclosure.
But for routine internal uses like billing, payment, or quality improvement, healthcare operations, even though those are allowed without patient authorization under HIPAA.
They still must adhere to the minimum necessary standard. The quality improvement team might need access to certain data, but maybe not the patient's name or financial info, for example. You still limit it to what's needed for that specific task.
All right, moving beyond just legal rules, let's talk about the ethical side, the idea of data stewardship. This feels like it goes deeper than just compliance checklists.
It absolutely does. Data stewardship is really about taking responsibility for the data. It's the ethical obligation to ensure that patient information is not only protected, but also accurate, reliable, and used appropriately throughout its entire life cycle. A data steward essentially accepts a duty to the patient, ensuring their information is managed correctly for their benefit, both now and for future care.
The National Committee on Vital and Health Statistics, NCVHS, developed some principles around this. What was their focus?
Their principles aim to build trust. They group them into four main areas. First, focusing on the individual's rights. Things like the patient's right to access their data, review it, request amendments, understand how it's used, transparency, and provide consent. Education about these rights is key too.
Okay, patient rights first.
Second, the responsibilities of the data steward. Clearly defining who is responsible for what aspects of the data and their fundamental duty to protect it. Third, outlining the needed security safeguards and controls. Basically, reinforcing the need to protect confidentiality, integrity, and availability, the CIA triad again.
Security is part of stewardship.
Definitely. And fourth, accountability, enforcement, and remedies. There need to be consequences for noncompliance, ways to address violations, and mechanisms to build and maintain public trust.
I thought it was really interesting that the sources highlighted that the NCVHS principles deliberately exclude data monetization or making a profit from data. Why is that exclusion so important ethically?
It's fundamental because stewardship is patient-centric. The primary duty is to the patient and the integrity of their care. If you introduce profitability, using patient data primarily to make money for the organization, you create an immediate conflict of interest. Decisions about data quality, how long to keep it, who gets access, those decisions must be driven by what's best for the patient and the healthcare system, not by potential financial gain. Keeping monetization out reinforces that ethical focus.
That makes perfect sense. Now, operationally inside a hospital or clinic, what's the cornerstone system for maintaining data integrity and enabling stewardship? It seems to be the Master Patient Index, or MPI.
The MPI is absolutely critical. It's essentially the permanent central directory or database of every single patient who has ever received care at that facility, its main job. To uniquely identify each patient and act as the key to link all their different visits, records, and encounters together into one unified health record.
So it prevents information from getting scattered across multiple charts for the same person.
Ideally, yes. But the MPI is also ground zero for some catastrophic data integrity errors if it's not managed meticulously. The sources point out two major threats: duplicates and overlays.
Okay, what's a duplicate record?
A duplicate happens when the same patient somehow ends up with more than one unique medical record number in the system. Maybe they registered under slightly different names, or the registrar couldn't find their existing record and created a new one. The result is a fragmented record. Their information is split across two or more charts. A doctor looking at one record might miss critical allergies or past history documented in the other record. Very dangerous.
And overlays sound even worse.
Overlays are a nightmare scenario for patient safety. This happens when information from two different patients gets incorrectly merged into a single medical record number. Imagine patient A's lab results getting filed into patient B's chart, or patient C's medication list overwriting patient D's.
Oh, wow. The wrong treatments, wrong diagnoses.
Exactly. You could have a healthy person suddenly appearing to have a serious illness based on someone else's data, or vice versa. Overlays can lead directly to serious medical errors. They are absolute emergencies when discovered.
The sources mention that these errors are often process problems, not just tech failures, and that centralized training helped one place reduce errors dramatically.
That's usually the case. MPI errors often happen during registration, maybe due to inconsistent searching procedures, typos, lack of standard naming conventions, or just staff rushing. The fix involves things like having dedicated, well-trained staff manage the MPI, using sophisticated algorithms to detect potential duplicates overlays, implementing clear procedures, and doing ongoing quality checks. Good processes are key to MPI integrity.
Okay, so the MPI manages patient identity. Let's define the data itself. The actual patient chart, the information collected for the purpose of providing care. That's primary data, right?
Correct. Primary data is the information gathered directly from or about the patient, specifically for diagnosis and treatment. The health record itself is the prime example.
And HIM professionals have specific tasks to check the quality of this primary data. You mentioned quantitative and qualitative analysis. What's quantitative?
Quantitative analysis is basically a completeness check. Does the record contain all the required documents? Is everything present? Is it authenticated meaning? Are all the necessary signatures or electronic approvals there? Think. Is the history and physical present? Are the physician's orders signed? Are discharge summaries complete? It's checking the presence and authentication of required components.
It's about the structure and requirements being met.
Yes. Whereas qualitative analysis digs into the content. It reviews the substance and quality of the documentation itself. Are there inconsistencies? Does the discharge summary contradict the progress notes? Are there ambiguous or unapproved abbreviations used that could cause confusion?
So making sure the story holds together and is clear.
Exactly. It reinforces that fundamental documentation principle. If it wasn't documented, it wasn't done. And equally, if it was documented, it needs to be clear, consistent, and accurate.
And if errors are found in the primary record, how do you fix them correctly, especially given potential legal issues down the road?
There are very strict rules. You can never obliterate or completely erase the original entry. Transparency is key. The proper way to correct an error, whether on paper or electronically, those systems have specific functions for this, is to draw a single line through the incorrect entry so it's still readable. Then you write the correction nearby, add your initials or signature, the date and time of the correction, and this is the reason for the correction, e.g. wrong date, entry error.
So anyone looking later can see exactly what was changed, when, by whom, and why.
Precisely. It maintains the integrity and legal validity of the record by providing a clear audit trail of all changes.
Okay, we've spent a lot of time on primary data, the stuff used for treating the patient right in front of you. Now let's talk about secondary data. This is where individual patient info gets leverage for bigger picture stuff, right?
Exactly. Secondary data is information that's extracted or derived from those primary patient records, but used for purposes other than direct patient care. Think research, public health tracking, quality improvement initiatives, hospital planning, education, even regulatory reporting. It's how we learn from the collective experience documented in millions of individual records.
What are the main ways organizations gather and manage the secondary data?
Two big categories are registries and large databases. Registries are focused collections of data about specific things, maybe a particular disease like cancer registries, a procedure like joint replacements, or a condition like trauma registries.
And within registries, there's a difference between hospital-based and population-based.
Yes, and it's an important distinction based on their purpose. A hospital-based registry collects data only on cases treated at that specific hospital. Its main use is usually internal quality improvement tracking outcomes for hip surgeries done at our hospital, for instance.
Okay, focused inward.
Whereas a population-based registry aims to capture all cases of a specific disease or condition within a defined geographic area, like a state or county, no matter where those patients were treated. These are vital for public health. They allow epidemiologists to track incidence rates, survival statistics, monitor trends across the whole population. Think state cancer registries feeding into national programs like SEER.
Got it. And beyond registries, there are these big national databases, like the National Practitioner Data Bank, NPDB.
The NPDB is a really important one for patient safety and provider oversight. It's a confidential database that tracks medical malpractice payments made on behalf of physicians and other licensed practitioners, as well as certain adverse actions taken against their licenses or clinical privileges.
And hospitals use this how?
Hospitals are legally required to query the NPDB about physicians when they first grant privileges, and then at least every 2 years after that as part of the recredentialing process. It helps ensure they're aware of any serious past issues before allowing a practitioner to treat patients in their facility. Other big databases include things like MedPAR, Medicare Inpatient Data, and HCUP, a family of healthcare databases used heavily for research.
So all this aggregated secondary data fuels data analytics, taking the raw numbers and turning them into insights.
Exactly. Data analytics is the whole science of examining that data to find patterns, draw conclusions, and ultimately support better decision-making. Your sources touch on different levels of analytics. We often start with descriptive, what happened, but the real power comes later.
Like predictive analytics.
Yes. Predictive analytics uses all that historical data to try and forecast what's likely to happen in the future. It answers the question, what will happen? Remember that COO struggling with staffing, using predictive analytics on past admission trends to accurately forecast next month's patient volume. That's the solution.
It gives you a heads up.
It does. And then the next level up is prescriptive analytics.
What does that do?
Prescriptive analytics goes beyond just predicting. It actually recommends actions based on the predictions and other factors. It answers, what should we do about it? So if predictive analytics forecasts that 20% jump in cardiac patients, prescriptive analytics might recommend specific actions like increase cardiac nursing staff by 15% or convert 5 surgical beds to cardiac beds for the next month. It suggests concrete steps.
Very cool. Now, for any of this analysis or even basic billing to work, the language used in the medical record needs some standardization. This brings us to the difference between a clinical terminology and a classification system. Sounds like a division of labor.
It really is.
Yeah.
They serve different but complementary purposes. SMEMED-CT, systematized nomenclature of medicine clinical terms, is the clinical terminology. Think of it as the language for the physician or clinician entering information into the electronic health record, EHR.
What's its main characteristic?
Granularity, detail. SNUMED-CT is designed to capture very precise, detailed clinical concepts. So instead of just saying smoker, the clinician can use SNUMED-CT to specify current someday smoker or former light tobacco smoker. It captures the nuances needed for clinical care. It's actually the standard for things like smoking status in required datasets.
Okay, so SNUMED is for the detailed clinical picture in the EHR, but you can't easily bill or run national stats on thousands of super granular terms, right?
Exactly. That's where the classification system comes in, and the main one used for morbidity reporting and billing in the U.S. is ICD-10-CM, International Classification of Diseases, 10th Revision, Clinical Modification. This is the language used primarily by the biller and coder.
And its purpose.
Aggregation and standardization for secondary uses. ICD-10-CM takes that detailed clinical information, often captured using SNOME-CT, and groups it into broader categories represented by standardized codes. These codes are used for processing insurance claims, tracking national disease statistics, measuring quality, resource allocation, essentially running the business and public health side of medicine.
Can you give a quick example of how they work together?
Sure. A doctor diagnoses a patient and, using SNOME-CT in the EHR, documents acute systolic congestive heart failure with severe left ventricular dysfunction. Very specific. The HIM coder then reviews that documentation and assigns the appropriate broader ICD-10-CM code, maybe something like I50.21 for acute systolic heart failure. That ICD code is what goes on the insurance claim and gets counted in national heart failure statistics.
So SNOME for clinical detail, ICD for billing and stats. You need both.
You absolutely need both for the system to function effectively.
Okay, let's wrap up by looking at quality measurement again, specifically hospital death rates. It's not as simple as counting everyone who dies in the hospital, is it? There's this thing called the 48-hour rule.
Right. This is a really important adjustment when calculating mortality rates used as quality indicators. The simple gross death rate just counts all inpatient deaths that occur within the hospital walls, divided by total discharges. Straightforward count.
But that might not reflect the quality of care provided by the hospital.
Exactly. That's why we have the net death rate, sometimes called the institutional death rate. This rate is specifically designed as a quality indicator, and the key difference is that it excludes deaths that occur within 48 hours of admission.
48 hours. Why that specific time frame? Does excluding deaths make the hospital look better than it is?
It's not really about making the hospital look better in a deceptive way. It's about creating a more meaningful statistic for assessing the quality of inpatient care. The logic is this. Patients who die very shortly after admission, within that 48-hour window, were often extremely ill or severely injured upon arrival. They might have been, frankly, unsavable, regardless of the care provided. Their outcome might be more related to the severity of their condition before they got to the hospital or factors outside the hospital's control.
So excluding them focuses the rate on deaths that happened after the hospital had a reasonable amount of time to intervene and provide care.
Precisely. By removing those very early deaths, the net death rate aims to more accurately reflect deaths potentially related to the quality of care, safety practices, and treatment effectiveness within the hospital itself. It becomes a more useful metric for identifying potential problems in inpatient care processes that the hospital can control and improve.
That makes sense. And if that net death rate or other indicators do suggest a problem, hospitals use tools like root cause analysis, RCA, to figure out why.
Yes, an RCA is a structured investigation method used to dig down and find the fundamental underlying causes of an error or a bad outcome, not just the superficial symptoms. The Joint Commission, for instance, requires hospitals to conduct an RCA within 45 days for any sentinel event, a serious, unexpected negative outcome.
And a common tool used during an RCA is the fishbone diagram, also called Ishikawa, or cause and effect.
That's a classic quality improvement tool, often used in the analyze phase of models like DMAIC, define, measure, analyze, improve, control. The fishbone diagram is basically a brainstorming tool that helps the investigation team organize all the potential causes of a problem visually.
How does it organize them?
It looks like a fish skeleton, hence the name. The head is the problem or effect you're investigating, or e.g. increase in post-op infections. The main bones branching off represent broad categories of potential causes. A common framework uses the 6 M's: manpower, staffing issues, training, skill levels, methods, policies, procedures, workflows, materials, supplies, drugs, quality of inputs, machines, equipment failure, software glitches, EHR issues, measurements, salty data, incorrect metrics, inspection problems, and Mother Nature, or environment factors like facility layout, noise levels, external pressures.
So it helps ensure the team considers all possible angles before jumping to conclusions.
Exactly. It forces a systematic look at all the contributing factors, helping to uncover the true root cause rather than just fixing symptoms. Hashtag tag outro.
Wow. Okay. We have really covered a lot of territory in this deep dive on health information management. We started right down at the foundation, the CIA triad: confidentiality, integrity, availability, and saw how those administrative, physical, and technical IPOS safeguards are designed to protect it, especially against that ever-present human element.
Yeah, and we navigated the legal side too, understanding the difference between a subpoena from an attorney, which needs careful handling, and a court order from a judge, which usually requires immediate compliance. Plus, the sheer power of the False Claims Act and its quid tam provisions for encouraging internal policing of fraud.
And then we moved into the core ethics of data stewardship, the critical role of the master patient index in preventing dangerous errors like duplicates and overlays, and finally how HIM transforms that primary patient data using analytics, specific coding languages like SNOMED and ICD, and even statistical nuances like the 48-hour rule to genuinely measure and improve the quality of care.
It really highlights that the health record isn't just a file folder or a database entry. It's this incredibly complex intersection of patient privacy, legal liability, operational efficiency, and population health strategy. Every single policy, every security measure, every coding decision, it all ultimately ties back to the quality and safety of patient care.
It truly underpins so much of modern healthcare. Now, we talked earlier about the minimum necessary standard, which is all about protecting privacy by limiting data exposure. But there's a tension there, isn't there? Many laws or regulations actually require hospitals to destroy patient records after a certain period, often tied to the statute of limitations for lawsuits, maybe 7 or 10 years, specifically to reduce privacy risks and storage costs.
That's right. Record retention schedules often mandate destruction after a set time.
So here's a final thought for you, our listener, to chew on. We've just spent all this time talking about how valuable secondary data is, how analyzing decades of aggregated health records fuels research breakthroughs, improves quality measurement, and powers predictive analytics that can save lives. If all that progress relies on having long-term comprehensive data, how long should your health record really be kept before that legal and ethical pressure to destroy it for privacy protection takes over? Where's the right balance?